Professor Venkatesh TK, Senior Interventional Cardiologist, working at Apollo Hospital, Bangalore. And today I'm happy to present before you a wonderful molecule called inclisiran. So inclisiran is a PCSK9 inhibitor, and unlike the other PCSK9 inhibitors, you can see inclisiran directly acting against the production of the PCSK9 inhibitor itself. So very high risk patients, if you can get down the LDL-C down to less than 50, it's very good. And high risk patients, if you can get the LDL-C down to at least around 75, it is better. It's important to strike early and strike strong for intensive LDL-C lowering to achieve targets in high-risk patients. And always remember, lower is better, and this has been actually endorsed by the 2023 ESC guidelines, then the 2022 ACC expert consensus decision pathway, and also our own Lipid Association of India update guidelines. So you can see in extreme CV risk category C, they go up to 15 milligram and 10 milligram of LDL-C, and this is very safe to achieve. In very high risk, if it's better to keep it as less than 50, that always gives less progression of atherosclerotic cardiovascular events and also reduces the major adverse cardiac events. Next slide, please. There's no significant association between very low levels of LDL-C and safety outcomes. And in fact, the 4-year trial showed cardiovascular benefit with lowering of LDL-C up to 10 milligram with no adverse events. So you can see here clearly that there are no serious adverse events, either systemic or any other systemic kind of problems. Inclisiran specifically works in the liver. It's the first-in-class small interfering RNA therapy to lower LDL-C. It mimics the body's process of RNA interference, which is restricted to the cytoplasm. It conjugates with the GI-NAC for specific uptake by hepatocytes. So low likelihood of target binding is there. So off-target binding does not exist. It is directly binding to the hepatocytes. And the inclisiran plasma levels decline within 24 hours, and in about 48 hours, you do not have any detectable inclisiran in the blood. So there is a reduction of LDL-C level in the bloodstream because of specific uptake of this molecule by the liver. So CDSCO approved indication is in adults with primary hypercholesterolemia, including heterozygous familial hyperlipidemia and non-familial hyperlipidemia. It's also advocated in mixed dyslipidemia as an adjunct to diet, in combination with a statin or statin with other lipid-lowering therapies in patients unable to reach LDL-C goals with a maximum tolerated dose of statin, or it can be used alone or in combination with other lipid-lowering therapies in patients who are statin intolerant or for whom a statin is contraindicated. We can see that the inclisiran is for patients with high cardiovascular risk, those with atherosclerotic cardiovascular disease, and the LDL-C remains off target in spite of standard lipid lowering therapy. We have given them statins, we have given them estimib, we have given them bempedoic acid, but even then their LDL-C goal is not at target. And it's also very useful in the treatment of heterozygous familial hypercholesterolemia. It's important that a 284 milligram pre-filled syringe of inclisiran is taken as a single subcutaneous injection at day 0, then at 3 months, and then this is followed every 6 months. Remember that this 3-month dosage is only for the first time. Now, why? Why is this 3-month dosage coming for the first time? That is because studies have shown that there is an initial bump in the LDL-C level at 3 months when inclisiran is given. So to overcome that elevation of LDL-C that happens at 3 months, for the first time only, the third 3-month dosage is given. Then after, it's every 6 months. And it is important that we should take this injection in a very monitored way. It's a subcutaneous injection in the abdomen, and it is given by healthcare professionals. It can even be given in the arm to the deltoid region, but it should be given to the fat pad. Next slide, please. Missed doses. If a planned dose is missed by less than 3 months, inclisiran should be administered and dosing to be continued according to the patient's original schedule. But then if it is missed by more than 3 months, a new dosing schedule, it should be taken as a fresh initiation of therapy. And then again, that dose that you're going to give is considered as day 0, then at 3 months, and then every 6 months thereafter. So inclisiran can be administered immediately after the last dose of a monoclonal antibody PCSK9 inhibitor. See, we have this evolocumab that's being given as a PCSK9 inhibitor that needs to be taken every 15 days. But we can give this, if you want to switch over from evolocumab to inclisiran, you can do that after the last dose of the monoclonal antibody PCSK9 inhibitor. And it is important that to maintain LDL-C lowering, inclisiran is administered within 2 weeks of the last dose of monoclonal antibody PCSK9 inhibitor. So if somebody wants to change over within 15 days, it is better to give inclisiran, not wait too long. And as per the CAC guidelines in 2023, what we find is that the non-fasting lipid profile within 24 hours should be taken. And we have to look at the LDL-C level. Now, the target is to achieve an LDL-C level of less than 55. And preferably, we try to see if we can put the patients on the standard treatment, including high-dose atorvastatin, either rosuvastatin 40 or 80 milligram of atorvastatin along with estimib. And once we do that, if we look at the LDL-C level, especially in high-risk patients, like for example, elderly patients more than 75, or those who are in CKD stage 3-5, or those with lipid-lowering therapy, but still not on loading, in spite of loading doses, they are still not on goal therapy for LDL-C, then we try to see by adding bempedoic acid, if the LDL-C is more than 55, they are coming down to the target levels. If they are not, then well, think of easily putting them on inclisiran therapy and try to get them down to an LDL-C level, at least by 3 months, to 30 milligram or less. This will be the lipid management in the setting of acute coronary syndrome. Of course, the non-HDL-C also is a primary, what you call as a co-primary target according to the Lipid Association of India and CAC guidelines 2023. And the Cardiological Society of India guidelines recommend that in patients with ACS, if an LDL-C target of less than 55 is not achieved, in spite of high-intensity statin, ezetimibe, and bempedoic acid, then another non-statin drug, PCSK9 inhibitors, and most importantly, inclisiran can be administered. So this is the bottom line of the CAC guidelines of 2023, and this is something that we should always remember. What do we see? We have the Orion 9 trial, we have the Orion 10 trial, and the Orion 11 trial. Now, these are 9, 10, and 11, which are the phase 3 trials, and they are all being completed. And here, inclisiran sodium 300 milligram, which is equivalent to 284 milligram, was used in these patients, and it has been carried out in United States, Canada, Europe, South Africa. And they have enrolled quite a number of patients and seen that there has been a sustained LDL-C reduction of about 50.5% when you used inclisiran. And effective LDL-C lowering was more by 50.7%. So what does this mean? With inclisiran as a strong complement to a maximum tolerated therapy, you can get your LDL-C down to less than 50% in more than half of these individuals, more than 52% of these individuals. So this translates to also a reduction in atherosclerotic cardiovascular disease MACE events. So in Asian patients, with ASCVD or high risk ASCVD, when you looked at the lipoprotein lipoprotein little a from baseline, you can see that inclisiran is one molecule which reduces the LPA level, LP little a level by 57.2%. This is, I think, the only drug so far demonstrated to bring down the lipoprotein A level ratio from day 60 to day 360. And there was definitely a reduction of almost 57.2%. So not only lipoprotein A, but inclisiran was shown in the Orient 10 trial to reduce the levels of other atherogenic lipids, and it also increased the HDLC level. So it reduced the apoprotein B triglyceride and also brought about an increase in the HDLC level. It was well tolerated, and the safety profile was similar to placebo. Apart from, of course, small injection site reactions, there can be a small injection site reaction, which is something like redness and itching, which is there for about 24 to 48 hours and completely disappears. No major adverse serious events were noted in the pooled Orion safety population. It's very safe, well tolerated, and up to 6.8 years of exposure, no adverse events have been reported. And of course, the Orion 8 trial, which is an open label extension trial, clearly showed that it was very safe and it reduced LDL-C levels in the long term while being well tolerated. Inclisiran acts in the cytoplasm of hepatocytes and not in the nucleus, so there is no risk of carcinogenicity and immunogenicity. That's very important thing that we should remember. That the Orion 4 and Victorian 2P going to be completed by 2026 and 2027, but whatever details we have now, they seem to show definitely benefit in terms of reduction of LDL-C. While the result of the CVOTs are ongoing, a recently published pooled patient level analysis of Orion 9, 10, and 11, which have undergone phase 3 trials, provided some insight into the possible cardiovascular benefit of treatment with inclisiran. So therefore, my friends, inclisiran is a wonderful molecule, and you can see that there has been definitely a very good response in terms of the outcome of reduction in LDL-C. I would like to share my own experience here. I had a patient with acute coronary syndrome. Of course, we have been using this molecule in a number of patients, but I've just picked one patient to just share my experience with you. In spite of standard doses of high intensity statin therapy along with ezetimibe and bempedoic acid, this patient with ACS was a very young patient, about 45 years, failed to achieve the LDL-C level. It consistently remained around 100 to 110 on repeated follow-up. So a decision was taken to initiate inclisiran. Once we did that, in about 3 months' time, when we rechecked the fasting lipid profile, we found that the LDL-C had come down to 11. It was very gratifying response, and we could even reduce the dose of high-intensity statin therapy, although it is not what is recommended. But because this patient had some kind of muscle aches and pains with the high dose of statin therapy, we thought we could reduce the dose, and we did reduce the dose and brought him back for the next 3 months. And we found that the LDL-C was close to 8. So therefore, it was a clear proof that inclisiran was working in him very fine. And we could next take off the bempedoic acid also and just continue with the statin, which was also still qualifying under high intensity statin therapy. It was not 40 rosuvastatin, but 20 rosuvastatin. And we all know that 20 to 40 rosuvastatin is considered as still high intensity therapy, along with ezetimibe and inclisiran. So we use these three combinations. And believe me, till this days has been almost about 9 months now. And repeated lipid profile shows the LDL-C to be a single digit or something close like 14, 18, 16, 12, things like that. Those are the values that with which we are seeing him on repeated lipid testing. And he is safe. He does not have any side effects. He doesn't feel weak. There is no cognitive dysfunction, and he is doing well, and very well, actually. I had a second patient, a lady who is about 42 years, with statin-induced myalgias. She was not able to tolerate even 10 milligram of atorvastatin. That was the problem. And her LDL-C was going at something like 145, 150. She had not suffered any cardiovascular event, but there was a very strong family history of atherosclerotic cardiovascular disease. So I had no choice but to start the patient on ezetimibe bempedoic acid without statin, and that did not achieve the LDL-C which we wanted. And in this primary patient, I wanted an LDL-C to be at least less than 100, if not less than 70, with a strong family history. And believe me, I started this patient on inclisiran. She continues to receive her 6 monthly dose of inclisiran even today in our hospital. And very gratifyingly, we are finding that the LDL-C is all the time around 45, 55 range. And she's doing extremely well. There are no side effects at all. And this she has been taking without fail. And every 6 monthly injection is paying a very good dividend. So with these two cases highlighting, we have been using inclisiran in a number of patients, and the attraction now is to use this inclisiran, especially in patients with acute coronary syndromes. That's where I think we are just waiting for the cardiovascular outcome trial data to come. And as we know, it's going to be somewhere in 2026. So once we have that, I think even in patients with acute coronary syndromes, we can be liberally using inclisiran. Thank you very much.